Lymphedema is a disease where the body is unable to adequately clear fluid waste from the arms and legs and other parts of the body back into the bloodstream. When there's a problem with the lymphatic system, fluid can build up in the arms, legs, and elsewhere. This is unfortunately an incurable and permanent and progressive condition. Lymphedema requires lifelong compression and lymphatic massage and can tremendously, dramatically affect quality of life for many patients. Sometimes it's a life-altering situation, as it would be for me as a surgeon if I had upper extremity lymphedema. I couldn't work. So we're particularly sensitive to these patients. So lymphedema is most commonly and classically diagnosed clinically, meaning it's diagnosed with a history and a physical. Although we now have imaging technology that can clarify and confirm that diagnosis. Historically, lymphoscintigraphy, which is a low-level isotope, is injected into the hand or foot affected extremity, and they can actually see how long it takes for that tracer to go up. A more recent test we've been doing for the past 15 years is called ICG lymphangiography. It involves also an injection, small injection of dye, where you can directly look at the lymphatic system. So you can see if the lymphatic vessels look normal or if they look damaged and if they're not flowing. Finally, there are non-invasive ways to evaluate for lymphedema, particularly in patients who are at high risk. So if you've had breast cancer or anyone who's had lymph nodes removed or radiated, you can step on a bioimpedance machine that will actually measure the electrical resistance across that limb. The more fluid in that limb, the lower the resistance, and the machine within a minute can calculate a score. But again, this needs to be diagnosed by a professional. The veins have to be checked, and you also want to make sure that there's no underlying cancer that's obstructing the lymphatics. So these are things that you want to 100% make sure about and not gloss over. Treatment for lymphedema has undergone almost a renaissance in recent years, because traditionally treatment was limited to compression and lymphatic massage. But now, as our understanding of the lymphatic system has improved, and more specifically, imaging of the lymphatic system has improved, now that we can see the lymphatic system, we can operate on it. And the surgeries that we do include 3 main surgeries. There are variations of these surgeries, but the most common ones are a lymphovenous bypass. This is also called lymphovenous anastomosis or LVB or LVA, they're all the same thing. And basically it's a plumbing solution to this problem where we're looking, we can identify with imaging if there's a blocked lymphatic. And if we see a lymphatic that ends in a dead end, we can make a small paper cut incision on the arm or leg, and with an outpatient procedure, sew that lymphatic into a neighboring vein to give the fluid an exit. Instead of going into a dead end, that fluid can then escape the limb. Another procedure that works very differently, called lymph node transplant, we're actually taking lymph nodes from another part of the body. I like to take them from the abdominal cavity, where there's 0 risk of causing lymphedema, but you're replacing what was removed. And those lymph nodes are like homing beacons for new lymphatic vessels. So they have growth factors that stimulate growth of lymphatics into the lymph nodes, and then that lymph gets shunted out the vein. Finally, SAPL, or suction-assisted protein lipectomy, which is a form of liposuction, is a debulking procedure that treats the fat growth part of lymphedema. Many times we use a combination of these procedures and variations, but those are the main procedures for lymphedema. My ultimate hope for the future of lymphedema is to find a cure for lymphedema. It's going to depend on the cause of the lymphedema. So if surgery caused it, probably a solution or cure is going to be surgery plus a combination of a drug to treat the immune response to the surgical injury. So safety has really been our guiding principle. More recently, I'd say in the last 7 years, we've been doing a lot more intra-abdominal lymph nodes that have no risk of causing lymphedema. And we've described not only these newer techniques, but how to actually do them from a microsurgical standpoint, how to optimize them. This is a continuing area of development which requires collaboration with surgeons around the world. So we freely exchange information, we teach, we learn from each other, and this is going to be a field that evolves together with a lot of different specialists.